Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. The topic of today's lesson is lacunar stroke. As you know, stroke is the acute episode of neurological dysfunction that lasts more than 24 hours. Stroke is the third most common cause of mortality and morbidity in the world. Lacunar stroke is one of the types of ischemic strokes. Well, ischemic stroke is secondary to the obstruction to the blood flow to the targeted organ, resulting in neuronal death. Injury to the nerve cells results in the neurological dysfunction, which, when not attended early, results in permanent functional disability. As you know, stroke is of two types, that is ischemic stroke and hemorrhagic stroke. Ischemic stroke accounts for 85% of the total stroke events, and hemorrhagic stroke accounts for around rest of the strokes, around 25 to 30%. Well, lacunar stroke is one of the types of ischemic stroke as a result of reduced blood flow in the small penetrating branches of the main arteries. Well, the clinical manifestations of lacunar stroke are said to be minimal or subtle because the area of the nervous tissue that is affected is small. Most of the cases of lacunar stroke are asymptomatic. Some they present with acute stroke of sudden onset, and recurrent lacunar strokes results in the vascular dementia. It's the most common cause of vascular dementia in the elderly. Well, early diagnosis and effective management of lacunar stroke and the associated risk factors should be attended to as early as possible to avoid the recurrence and prevent the permanent disability. Well, lacunar stroke as such indicates presence of a major disease, that is non-stenotic thrombotic phenomena in the large vessels, that is main blood vessels that are supplying the brain. What are the main blood vessels that supply the brain? Midcerebral artery, anterocerebral artery, basilar artery, vertebral artery, okay? Basilar artery dividing into two posterior cerebral arteries, okay? These arteries are connected together encircling the brain. That is called circle of Willis. All these, the branches of these arteries, they supply the surface of the brain, that is cortical matter, and the deep structures of the brain that are supplied by the penetrating branches of the arteries of circle of Willis. They supply the deep structures, that is subcortical structures are supplied by the penetrating branches of the circle of Willis. Say middle cerebral artery, say the basilar artery, okay, so forth, so on and so forth. That means when there is obstruction to the flow in the penetrating arteries, penetrating branches, that means there is a disease behind involving the major arteries. That is atherosclerotic plaque with thrombosis formation. Non-stenotic atherosclerotic plaque or a thrombotic phenomenon at the site of the erythematous plaque is the nidus for embolic phenomena into the small penetrating branches, thereby causing lacunar stroke. Okay. If a patient presents with the features of lacunar stroke, you should not forget the underlying cause behind. Okay. There is a major factor that is responsible for lacunar stroke. the thing that is the thrombotic phenomena or atherosclerosis of the large blood vessels. Okay. So look at this picture. The Lacuna stroke affects the deep structures of the brain. It does not affect the cortex of the brain. This is otherwise called non-cortical stroke. Okay. The risk factors are hypertension. Hypertension is the major factor that results in Lacuna stroke. Okay. The main cause of Lacuna stroke is hypertension could be the risk factor. The pathological phenomena that is happening in the penetrating branches of the major arteries, that is in the small vessels, is lipohydrinosis and microatheromas. In addition to that, embolic phenomena that occurs from the dislodgement of the particles of the atheroma or thrombus that is there in the large blood vessels, or embolic phenomena from the of cardiac origin. Okay, that results in the reduction in the blood flow in the penetrating branches of these large vessels, results in Lacuna strokes. This picture shows, as I told you, there is a circle of Willis formed by the branches of the basilar artery, that is posterior cerebral artery, and the anterocerebral arteries, and the anterior and posterior communicating arteries. Penetrating branches from the arteries of this particular circle of Willis, that is the major artery that supplies the brain. They are obstructed, thereby resulting in Lacuna strokes. You see, this picture shows this is the middle cerebral artery. These are the penetrating branches. Okay. Obstruction in these penetrating branches results in the ischemic injury, thereby causing infarcts and damage to the subcortical areas. The extent of the damage and the part of the brain that is affected determines the clinical spectrum of manifestations. Okay. Because cortex is not affected, the features of loss of judgment, loss of sensorium, seizures, they are less common. Okay, in Lacuna strokes. They present with the other manifestations, which we are going to talk in the clinical presentation. There are several Lacuna syndromes that have been explained, described in the clinical spectrum of the Lacuna stroke manifestation, which we are going to touch upon. By and large, the clinical manifestation depends upon the area and the extent of the brain tissue that is affected, that is subcortical white matter. Well, this is Lacuna strokes are the common cause of cognitive impairment in the young. And the most common cause of dementia in the elderly. The major etiological factor is the lipohydrinosis of the small vessels, resulting in a thickening of the vessel wall, thereby causing narrowing of the lumen. That results in the reduced blood flow to the tissues. Another factor is the microatheromas, which again cause the obstruction to the flow, thereby resulting in Lacuna strokes. Other risk factors being hypertension, diabetes, hyperlipidemias, vasculitis, and other infections. Okay. Whatever may be the risk factor, the ultimate result is the obstruction to the flow of blood in the penetrating branches of the large vessels that are supplying the brain. And the ischemia and the infarction involves the white matter of the brain, that is subcortical white matter. It could be thalamus, basal ganglia, or internal capsule, or the pons. Okay. By and large, the size of the infarcts, they do not, the size of the infarcts varies between 3 millimeters to 20 millimeters. Only 70% include less than 10 millimeters. Okay. These infarcts usually present with acute stroke manifestations of sudden onset, but few are asymptomatic. Okay. Clinical presentation is usually acute of sudden onset. Some may be gradually progressive, stepwise increase in the severity of the symptoms. Well, because it is a subcortical white matter that is affected, the manifestations of behavioral changes, seizures, aphasia, blindness are absent in the lacunar infarct because it is subcortical lesion. In the same way, memory, language, judgment are seldom affected in the lacunar strokes. Well, there have been more than 20 clinical syndromes of presentation of lacunar strokes. And to mention few, I'm going to touch on 5 of the important clinical syndromes of lacunar strokes. That is pure motor, pure sensory, motor sensory, ataxic, and dysarthria, clumsy hand. The patient may come to you with this saying that I'm feeling weakness in my hand. So this is rather misdiagnosed, misdiagnosed, and adequate attention is not paid in order to put the patient in detailed workup. But recurrences are very common, okay? And that may lead to the permanent motor disability and dysfunction. So it is very important to pay attention to the subtle manifestations of neurological dysfunction, which are due to lacunar infarct. So pure motor, it is because of the involvement of either the anterior limb of the internal capsule or corona radiata. Okay. It accounts nearly about 45% of the total lacunar strokes. It is associated with the contralateral hemiplegia involving the face, leg, and the limb. So that means there is a upper motor neuron lesion signs on the contralateral half of the body. Okay. Sometimes there could be hemiplegia. Sometimes there could be weakness of one limb or one hand. Okay, showing the upper motor neuron signs. As I told you, cortical signs like aphasia, visual disturbances are classically absent. Coming to ataxic hemiparesis, this accounts to 14 to 18% of the patients. It involves the internal capsule, pons, and corona radiata. Presents with the weakness of the opposite face with limb ataxia. The ataxia is the most prominent feature in this particular set of lacunar stroke. Pure sensory, it amounts to nearly 7% of the cases because of the involvement of the thalamus and corona radiata. Presence with abnormal or absent perceptual sense of opposite face, arm, and leg. Okay. There is the loss of pain, temperature, touch, pressure, visual, auditory, and taste senses. Because this involves the white matter. White matter of the ascending sensory tracts. You got the posterior columns, you got the lateral spinal thalamic tracts passing through the thalamus, okay, from there into the internal capsule, from there into the post-central gyrus area 312. Because thalamocortical projection is affected, okay, which contains white matter. That results in the loss of these sensory modalities and the opposite of the body. This is again because of the involvement of the deep branches of the middle cerebral artery. That is penetrating branches of the middle cerebral artery. Please keep this point in mind. Most of these penetrating arteries arise from middle cerebral artery. Okay. In Lachner stroke, the lesions involves the penetrating branches of the middle cerebral artery in particular. The maximum number of penetrating branches of the branches that are involved in the Lachner stroke are branches of the middle cerebral artery. Okay. The rest of the areas are next to the commonness with regard to the commonness of the middle cerebral artery. The most common penetrative branches are those from the middle cerebral artery. Okay. The next syndrome is the dysarthria clumsy hand syndrome. Here, the patient is not able to speak properly. It is because of the involvement of the muscles of articulation of the language. Language formation is the cortical function. Okay, because cortex is intact, language formation is normal, and but only the articulation of the speech is affected. So the patient suffers from dysarthria. Okay. And fine movement of the handwriting is also affected in these patients. Well, one important point to remember is the strength is normal. Okay, even the hand is clumsy and the patient is not able to execute the fine motor activity like handwriting, his muscular power is normal. Motor and sensory stroke. This is the second most common type of Lachner stroke syndrome, affecting nearly 20% of the cases. It is associated with motor weakness, sensory loss, and opposite half of the face, arm, and leg. This is because of the involvement of the internal capsule, thalamus, putamen globus pallidus, and cardiac nucleus circuit. Okay. These are the 5 common type of the Lachner stroke syndrome that I wanted to highlight. My dear student, these are a few important points that you have got to remember. Lachner strokes manifestations are fluctuating. Okay. Sometimes with rapidly deterioration, the functionality, resulting in the neuronal dysfunction. That means features are very much fluctuating and showing the rapid deterioration sometimes. 40% deteriorate in the first week of presentation. Okay. Even after admission, the patient is seen rapidly deteriorating. But spontaneous recovery in 1/3 of these patients who are deteriorating can be seen. Okay. The rest of the patients suffer from permanent disability. So monitoring after the admission is very important, and treatment should be effective. Okay? Well, Lacunar infarcts are the common cause of vascular dementia and cognitive deficit. Well, this part is clinically neglected. You must keep this point in mind. So MRI scan demonstrates multiple silent lacunar strokes in these individuals. So that means the elderly with the presence of risk factors, say hypertension and diabetes, they present with a subtle neurological dysfunction, say memory loss. They say, I'm not able to remember what I wanted to do. Now, this is attributed to the old age. And the proper workup has been not done properly. Until that time, he rapidly deteriorates and lands in permanent neurological disability. So this is already very, very important to consider the subtle neurological manifestations and go ahead with the workup. Okay. MRI scan is very sensitive to give the cause of this particular neurological dysfunction, that is progressive cognitive impairment, which has to be suspected and should be properly evaluated and treated early so as to avoid permanent motor sensory disability. So whatever may be the clinical manifestation of the patient that comes to you, say with the subtle motor dysfunction, or it could be sensory motor dysfunction, or patient has come with the ataxia, or patient has suddenly developed dyslexia, not able to speak properly. Okay, so suspect in the light of the presence of risk factors like hypertension and diabetes. Proceed with the imaging of the brain. CT scan may not be that sensitive, but do the CT scan to exclude cerebral hemorrhage or sometimes calcifications. MRI is more sensitive. It will give you the presence of infarcts in the subcortical area. Okay. Size of the infarct may vary from 3 millimeters to 20 millimeters, and site of the infarct is diagnostic. These infarcts are seen in the subcortical area, more so in the midcerebral artery. Proceed with the carotid Doppler, MRI angio, and do thorough embolic evaluation. Okay. Look for the origin of cardiac emboli, complete cardiac evaluation with regard to echocardiography and ECG and X-ray chest, hematological workup to exclude presence of infections. Other thrombophilic conditions have to be excluded. And look for comorbidities like diabetes, right? And treat these conditions effectively. Treatment: stabilize the patient if he is in acute condition, provide oxygenation, keep the PCO2 more than 90%, get the blood pressure down to systolic 130 mmHg, treat diabetes to maintain the HbA1c around 6.5 to 7. After stabilizing the patients with regard to the hydration with normal saline, providing oxygen therapy to get the PCO2 more than 90, then proceed with the thrombolytic treatment. Okay. If the patient presents early, earlier than 4.5 hours, provide with the thrombolytic treatment with tissue plasminogen activator. Most of the patients are going to improve, recover from that is lacunar stroke with TPA. Okay. If they presented late, then proceed with thrombectomy if the vessel is approachable. In certain of the cases, limited cases may be subjected to thrombectomy. Thrombectomy has to be delayed. Sorry. Double antiplatelet therapy has to be started if the patient is out of TPA window. Okay. And he is with non-cardiogenic emboli. Okay. And it should be delayed. That is, double platelet and antiplatelet therapy has to be delayed if he has taken thrombolytic treatment. And continue the double antiplatelet therapy for 21 days. Okay. Treat the comorbidities like hypertension to maintain the systolic pressure at 130 mmHg, and treat diabetes to maintain blood sugar level at 60 to 180 milligrams per cent, and HbA1c between 6.5 to 7. And continue statins to keep LDL to below 70 milligrams per cent. This is the line of management of a patient with lacunar stroke. Okay. And take care of the primary prevention, advocate secondary prevention. Well, primary prevention is that has to be observed to prevent the first episode of lacunar stroke. Maintain a good lifestyle, good nutritive diet, maintain the body weight, and do regular exercises. And if you got the hypertension and diabetes, keep them under control to prevent first episode of stroke. Secondary prevention is to prevent the recurrence of the stroke after first episode. Okay. This is carried out with observing the good healthy lifestyle and getting the hypertension, diabetes, other comorbidities treated, and they must be under good control. Okay. Well, these are certain of the pictures where the lacunar stroke is common. Lacunar stroke affects these particular areas. That is subcortical white matter. This is the cortex containing the gray matter. These are the areas of white matter where the axons from the gray matter they run to the different areas. Okay, they'll cross to the opposite cerebral hemisphere. They come down and connect to the lower centers in the spinal cord. Okay. The subcortical area constitutes the dense white matter containing the axons of the nerve cells. These are the potential areas for lacunar stroke. MRI showing the brain, MRI of the brain showing presence of lacunar infarcts. Their size, as I told you, varies between 3 mm to 20 mm. They are located in the subcortical white matter. This is the cortex folded into dry cell side. This is the subcortical area showing the presence of. This is the circular village and branches for the circular village. That is the middle cerebral artery. Its penetrating branches showing their obstruction, thereby resulting in lacunar stroke involving the white matter. That is subcortical white matter. Thank you very much for patient listening. Hope it is interesting to you, please do not neglect the old patients or anybody that comes with the subtle manifestations of neurological dysfunction. In the light of the presence of risk factors like hypertension and diabetes, consider Lacunar stroke as the diagnosis and proceed with the thorough investigation and treatment. Provide secondary prevention measures so that patient will not suffer from permanent neurological disability. Thank you once again. See you in the next class. Until that time, bye-bye.